on how bad it is, depending on how long it is, and I'll show you how I know this. Because we took 13 patients and we did the treatment on them, and it was not super controlled. So in some of the patients, they completely got better in 2 treatments. In other patients, they completely got better in 10 treatments. 10 was the very most, but the average was 6. This is their pre and post pain. Their pre-pain is the blue, and their post-treatment pain is the red, as you can see. And the reason that I have here allodynia and shock is because they have 2 kinds of pain. They have like really severe skin pain, and that's allodynia, like where the wind blows on their skin and it hurts really bad. And then they have the shock-like pains, and the shock-like pains feel like somebody put a hot poker right smack in the middle of the nerve and it shocks the nerve. And that is like, you know, they have to moan in agony when that kind of pain happens. The shock-like pains are just the worst. So we collected data on both the allodynia and the shock, and look at the befores and afters. I mean, is that incredible or what? That's some pretty incredible results. So we wrote this nice paper, and I presented it. I don't have a picture of my poster that I presented at the Society of Integrative Oncology, but I you know, made a nice poster and I presented it, and it got published in the Journal of Society of Integrative Oncology. And you know, that journal eventually shut down, so this paper is now available, open access, so you all can get it, and I highly recommend having it. Because if you follow this protocol, and it also talks about getting the patients off of the narcotics, and you know, the way you do that with during the acupuncture treatments, when you do what, you will definitely help your PHN patients. You're going to get rid of their pain. So I love this so much, and this was my way of really sticking it to the Western medicine people and saying, I've got something that works and you don't. So I applied for an R21, and it got scored, which was really nice because a lot of times they don't even get scored. And they gave me a lot of feedback. The biggest feedback that they gave me is that they didn't approve of the institution. When you apply for an NIH grant, you actually, as the person, don't get the money. You're writing it up and you're the principal investigator, but the institution that you applied through, they're the ones that get the money. And they have to have an accounting department that manages the money. And I thought that I was going to be like the pioneer who was the first person to apply for and get NIH funding at Bloomington Hospital. And that was a very bad idea, because the NIH doesn't like to give money to hospitals or even small colleges and smaller universities that don't do a lot of research. They like to give money to places like Indiana University School of Medicine that gets another NIH grant every other day. They, you know, that's all they do is manage their NIH funding. So the NIH said, don't do this through Bloomington Hospital. Don't resubmit this through Bloomington Hospital. Do it through Indiana University. You're connected with them. And I said, but I've never done a study where I was the PI through Indiana University. And they said, figure it out. And I said, well, you know, how do I even use the departments? And they said, figure it out. When you figure it out, you reapply, and then, you know, we'll consider actually giving you this money. So that's what I mean when I say that I didn't have enough experience conducting RCTs. They wanted me to conduct the RCTs at the university. They wanted to see that I could work with the statisticians, that I could work with the people who were writing the database to input all of your data, that I could work with the recruiters, that I could work with the doctors, the oncologists, the pain doctors. They wanted to see that I could work with all those different departments that don't even really talk to each other. The PI is the middleman that talks to all the different departments. So they wanted to make sure that I could do that before they were going to give me any money. And yeah, and Bloomington Hospital didn't have the infrastructure to conduct that study. They had an IRB. They didn't have a data and safety and monitoring board, which isn't really necessary, but they didn't know what one was, and they never had an accounting. They had an accounting department that handled their different departments, but they never had one that handled a fund, a grant, a large grant. So that was the problems with the PHN study. So then I decide, all right, I'm going to do what they said, and I'm going to do my studies through the Simon Cancer Center, Indiana University School of Medicine, and that's a picture of them. And it's not a very nice picture, but it's a beautiful facility, and I love this little sculpture thingy that they have in the front. And the radiation oncology department is where Peter Johnstone's the chair, so it sort of made sense, and I figured through him I could get connected with the different departments. So we created this acupuncture for fatigue caused by radiation therapy study. And the fatigue is pretty significant in the people that it hits, but it doesn't hit everybody. So we decided to make it a multi-center pilot study at IU School of Medicine, which is not necessarily a good idea because it just makes it more complicated. And originally it was going to be just the Simon Cancer Center and the IU Health Methodist Hospital and the IU Health West. And I'll tell you why. Because they're all under the same IU Health is connected with Indiana University. So there's actually one research nurse who could recruit all the patients at every single location. So that made sense and it made it kind of simple. And the one acupuncturist that I use can go to all these different places, the 3 different places, so that made sense. So there was a lot of things that made sense. Peter Johnstone at the time was over the Simon Cancer Center and over the Methodist Hospital, and the IU Health West radiation oncologist was this other guy that I knew when I worked with Central Indiana Cancer Centers. So we knew each other, and and it just kind of worked out. So we thought, yay, let's do a multi-center study. Well, we hired this, as a part of our team, we hired this measures expert. Shelley Johns was her name. Brilliant, brilliant, brilliant woman. And she has her PhD in measures, if you can imagine that. Measures are questionnaires. All right, so there's somebody that actually has a PhD in questionnaires. Oh my God. She, verbose, you've never seen anyone that has more words come out of her through her mouth and on paper, and it's all over my head. And so we had like 10 questionnaires for these people that she wanted them to fill out. And in this study, in the middle of the study, I use Department of Radiation Oncology Study Coordinator left. So all of a sudden, I didn't have a study coordinator. And I didn't know how I was going to create my database, and I didn't know how I was going to enter my data, and this was a lot of stuff. So I called Tammy Sajak, and I said, oh my God, what am I going to do? And Tammy said, well, I'm right now learning this new database program that we have called RedCap. And I need to practice on some, study. So I'll go ahead and build your database on RedCap, and I won't charge you anything. And I was like, oh, thank you so much. So that's how I started working back with Tammy again. And then IU Health Goshen. Oh my gosh, naturopath, graduated from Bastyr, I think. At the IU Health Goshen naturopathic cancer internship thingy. Naturopathy isn't even legal in Indiana, but we happen to have this internship place for naturopaths. real naturopaths. And so she calls me up and says, well, we want to be a site too. And at first I thought, oh my gosh, that's going to make things really impossible. But IU has a department that actually helps you add an additional site. So all of a sudden I figured out I don't even have to worry about that. These other department people will do this for me and add this different site. And that was really nice. You know, working with a big university is great in that they have people that can help you with almost everything, and they do a lot of the work. And so that's how IU Health Goshen got brought on board. But you know what? And that's our little study schema for that one. And that one, these were all the different things that at first we were just going to examine fatigue, but then when Shelley got on board, the measures expert, she wanted to do depression, anxiety, quality of life, and I wanted to do efficacy, the placebo, because it's a needleless placebo, and it made sense to ask we were going to blind the subject with a relaxation mask, and do either true acupuncture or the needleless placebo, which is you put the pipette on the skin, you swab the skin, put the pipette on, tap it, give it a little twirl, and then take it away. And then do, you know, like a bunch of points, not necessarily acupuncture points, but, you know, any old points. And that placebo has been done and has been validated and proven before, but it's not very popular, and it's not real big like the retractable needle that costs $4 a piece. And I don't like that thing anyway. So the problems were, the biggest problem that I had was personnel changes in the supporting departments. We made it through the scientific review committee, and our scientific review committee really does all the work. They get the paperwork ready for the IRB, and so I don't have to do all the IRB paperwork myself, which I used to have to do at Bloomington Hospital. It would, 18 different piles of, you know, like 100 pages here and 100 pages here and 100 pages here, all in my living room. I didn't have to do any of that because the scientific review committee at IU did it for me. But some of these people in the scientific review committee and in the supporting committees left and moved to different departments. There's so much departmental moving because if you stay in your own department, you don't get raises, but if you move to different departments, you get more money. So everybody at IU constantly moves to different departments. And man, jumping around and dealing with all these personnel changes really sucks. We had major problems. We couldn't recruit anybody. We asked, so far on this study, we have asked 10 patients, and nobody wanted to be a part of this study because of the many, many questionnaires. And it was going to be done in the radiation department while they were there already getting their radiation. It was going to be week 4, 5, and 6 of radiation. No extra visit. All they had to do was, you know, lay down, have needles in for 15 minutes after their radiation treatment. Not a big deal. But they didn't want to do it. Then the big bomb dropped. My mentor, the super big wig, Peter Johnstone, leaving as chair of IU School of Medicine. So now what do I do? Because that's my lifeline to research. Well, you always have a plan. In research, you always have to have a plan because everything changes and you have to have a backup plan. If you don't have a backup plan, you figure one out fast. All right, we were also working on this self-acupuncture study, yin tong versus a control point for anxiety in chemo patients. And in this study, we had 3 co-PIs, and it was funded by both departments, the radiation oncology and medical oncology, and we only had 1 questionnaire. So we learned our lesson from the first study and made it through the scientific review committee, now at the IRB. If it makes it through the scientific review committee, it's going to make it through the IRB. IRB really, the SRC they're the ones that have all the problems, and they ask you to change this and that's and this and that's. And then when it goes to the IRB, it's usually a clean sweep. So that's still in process. Peter Johnstone's one of the PIs, but he's gone now. This study can still go on. The other study, I don't know what's going to happen with it. So far, I know that recruiting is really not working out, and the next chair of the department may hate acupuncture. If that's the case, that study can't go on. So we're just going to have to figure it out. This is the Yin Tong study, and another study that I'm going to tell you about in a minute is going to be done in the chemo drip room. And this is our chemo drip room, and this is our chemo drip chair. And this is actually Lance Armstrong. And Lance Armstrong had his, woo, is that me? Too close? Okay, I'm moving away. And so Lance Armstrong, everybody knows who Lance Armstrong is, right? Really famous guy. And he decided to have his cancer treatment at Indiana University School of Medicine, Simon Cancer Center, because the top cancer doctor for his type of cancer in the world was there. And that doctor's name is Larry Einhorn. And it just so happens that Larry Einhorn is a co-PI on this study. So thank God for me. Tammy Sajak jumped on as a co-PI because we still didn't have anybody to put together the database and the new REDCap system. And Tammy said, I'll do that one too. So, so now we've got Larry Einhorn as the medical oncology, Peter Johnstone is the radiation oncology, but now he's not with us anymore. So he drops off, and then me as the acupuncture PI. 3 PIs. This one can still go on. So when I found out that Peter Johnstone was no longer going to be with us, the first thing I did was I contacted Larry Einhorn. And I said, what are we going to do? What am I going to do? What, help me, please. And he sent me, what? Oh, these are the good things about the self-acupuncture study. Simple, inexpensive, 1 questionnaire, crossover design. So we take the patient, when they first have their first chemo treatment, they get the Yin Tong. When they have their second chemo treatment, they get the control point, or vice versa. So same patient. No LAC needed, which is not really cool. I don't like that. I like to employ LACs in the community to do these research studies. We give them $100 per visit, and that handles their travel and their treatment. And so the study can still be done if we lose Peter Johnstone. All right, so Larry Einhorn sends me this thing. And this is an announcement from the Simon Cancer Center and from the Neurotoxicity Working Group, NWG. And they say, we want pilot project proposals with a focus on chemo-induced peripheral neuropathy or chemo brain, which is the chemo-induced cognitive dysfunction. We're going to give you $50,000, and we're particularly interested in getting applications from investigators who, with this additional support to do these pilot studies, are likely to obtain extramural peer-reviewed funding. So they only want to give the money to people who've already gotten NIH funding for other stuff. And it's because the NIH wants to do collaborative studies on neurotoxicities from chemo that will not only test the efficacy of the treatment, but also the mechanisms of action behind why the treatment works. So they want the medical oncologists to get together with the neuroscience researchers, and I'm going to tell you, the oncologists never get together with the neuroscience researchers. They don't know each other at all. They don't care about each other. They don't talk to each other. Their buildings are many, many blocks away from each other. And the only reason that I know some people in neuroscience is because of Tammy Sajak, because she was a neuroscience PhD, She's still my friend. She came to an acupuncture conference with me, which is why Tracy knows her. Where'd Tracy go?
She went to Park with us.
All right, well anyway, that's why Tracy knows her. And months ago, Tammy connected me with this guy named Fletcher White, who was this really smart neuroscience guy that loves neuropeptides but also loves immune cells. Normally neuroscience guys only like neuropeptides and they don't like immune cells, and I like immune cells because acupuncture increases immune cells and decreases cytokines, the inflammatory immune cells that we don't really like. And so I'd already met with Fletcher White and I already thought that he was really cool. So when Larry Einhorn sent me this thing, I was like, oh my God, let's get Larry Einhorn and Fletcher White and Tammy Sajak in a room together and see what we can do. So that's what we did. And we came up with this idea. Multidisciplinary study, meaning neuroscience and clinical oncology, acupuncture for the relief of taxane-induced myalgia and arthralgia in breast cancer patients, and we're also looking at chemo-induced neuropathy. And Larry Einhorn is incredibly famous and incredibly busy and also kind of old. And he said, listen, I have this new protege who is really into new research ideas, and he's eager and he has a lot of time on his hands and he can write well and he likes acupuncture, so let's bring Costa Albany in the room. So they brought Costa Albany, we all totally connected, and so the co-PIs on this one are Tammy, Fletcher, Costa, and me. And we wrote our letter of intent. Do I have anything? Oh yeah. The object of our proposal is to first evaluate the efficacy and the use of the acupuncture for the post-chemotherapy myalgia in the breast cancer patients who are being treated with paclitaxel. But second, to provide insight into the possible mechanisms of action for its effects. And our aims are the clinical benefit of the acupuncture for the myalgia and arthralgia, and also long-term neuropathy. The aim, too, is to determine the impact of the acupuncture on inflammatory cytokines. So, the patient gets into the chemo chair, has their blood drawn first to see if their white blood cell count is high enough to get the chemo. While they're waiting for those results, which take 45 minutes, we give them acupuncture. From that blood that we send off, we also test for the cytokines before acupuncture. Then they get the acupuncture. Then they get the chemo. Then 2 hours after the chemo, actually the chemo doesn't go into their system till about an hour and a half later. Because first they get some fluid. Then they get some Benadryl, then they get some prednisone, then they get some chemo. So there's like a lot of other stuff that's got to go in there before they even get the chemo. So we draw the second set of blood about an hour and a half after we've done the first, or it's 2 hours exactly after the first set of blood, but about an hour and a half after the acupuncture, before the chemo goes in. And then another 2 hours later when the chemo's about done. And then we're doing that 3 times over a 12-week period. We're doing acupuncture 12 weeks in a row. While they're there, they're only there 1 time a week getting their chemo drip. It's not inconvenient for them at all because we're doing the acupuncture while they're waiting there anyway. And it's a very comfortable recliner. We're doing the same kind of thing where it's the acupuncture compared to the needleless placebo with the nice little relaxation mask. And, it's always a good idea for these pilot studies to say that one of your aims is to determine the feasibility of recruiting patients to participate in this trial. Because as you heard from one of my other trials, it wasn't feasible. It didn't work out. So it would be dumb to ask the NIH for money for me to do that trial again because it didn't really work out. But we think this one's going to work out. We're going to give them only one questionnaire because we already learned from our mistakes that only one questionnaire is the best idea. And most of our information will come from their blood. So my take-home points for this little part of this spiel is to network like crazy. Network with people at the societies, the Society of Integrative Oncology, the Society of Acupuncture Research, all the people that you know. Remember everybody, write down everybody's name, keep like a file of everybody's cards, and collaborate with people, all kinds of people, MDs, neuroscience people, people that write really well. You know, somebody that I can't live without is my copy editor, Lynn Eder, for the American Acupuncturist. She's not an acupuncturist. She has nothing to do with the profession. She has a degree in like English or whatever, but thank God, because my writing style is kind of crude and I'm not very eloquent in the way that I write. So I can write a paper and she can take it and make me sound a lot more eloquent. And you know, you've got to have people like that. This work is not done by one person. This work is done by a team, and you got to know how to put your team together. Focus on the process and not the final outcome, because most of the time you're going to learn a lot just through the process, and it's not really about the final outcome. What we're going to do for the next 3 hours, this putting together, you know, a pilot study kind of workshop thing, I copied a lot of that from that fatigue study that's probably never going to be done. But I have a 30-page protocol and informed consent that you guys now all have sort of a basic outline of, and you can use it for your studies if you want to do studies in the future. And I have certain areas in that, I think I've got it in italics or blue or something, that are literally direct quotes from my protocol that was kind of put together by the scientific review committee based on my ideas. But I'm telling you, plagiarize, copy that stuff, use it as a template and copy. We're allowed to do this in research. We're not allowed to plagiarize each other's published works that are in journals, but we're allowed to plagiarize each other's protocols. If we say, please plagiarize my protocol, you know. So please plagiarize my protocol. Other people did it for me, so I'm going to do it for you. You know, we're kind of open to that in this profession. So really, it's all about the process, it's all about the living, it's not about the final outcome, the data. Yes, the data is really cool, and reporting the data is really cool, but a lot of the studies that you're going to do, you're not actually going to get to the place where you get the data. But it's still, for me, really fun. I like it. I know not everybody likes it, and it's not fun to everybody, but for me it is. You got to keep an open mind, because there's going to be a lot of changes throughout the way, and you got to learn how to roll with the changes and not get too upset. And that's it. And we're 5 minutes over, which is really not that big a deal. But does anyone want to ask me anything about this before we take a little break and then go on to the next thing? Yes?
I'd like to hear you talk about the relevance of the OCOM study.
Yeah, that was the same thing I asked Peter Johnstone. And he said, I love yin tang. And I said, I don't. I love peripheral nerves. And it's not like, it's like in the middle. And he said, yeah, but it's so centering. And I said, well, I guess. loves yin tong for some reason. It was his idea. I did not come up with that protocol. I like peripheral nerves. I wouldn't have come up with a yin tong protocol. But it's, I don't know, it's interesting. There's a lot of very, what do you call them? Really out there, big personality people in my life who love yin tong, and they're all men, and they're all large, and they're all